This one's your antiarrhythmic heavy hitter, amiodarone. Let's chat about it. My name is Leah. I've been a CVSU nurse for 18 years, and I love to talk about all things ICU. And in this series, we're talking about drips we commonly use in an ICU setting. For amiodarone, we usually start with a bolus and then flip over to a continuous drip. What I've seen most often in my practice is that after the 150 milligram bolus is finished, then the drip is started at 1 milligram an hour for 6 to 8 hours, depending on where you work. And then after that 6 to 8 hours, it cuts down to 0.5 milligrams an hour. And so the doses are usually like 33.3 cc's an hour, and then it switches down to like 16.7 cc's an hour. That's what I've seen most places that I've worked. So when are we going to use amiodarone? It's going to be when we have some sort of dysrhythmia. So most commonly, I see it a lot in our patients that come out of surgery and they've had some AFib. They'll already have bolus them and be on it. I also see it a lot if a patient came through the ED with a VTAC, VFib arrest. They usually are started on amiodarone. The thing to know about amiodarone is that it has a long half-life, which means it sticks around for a long time. So if you have a patient that's on amiodarone, know that the effects will continue long after it's off, and know that those effects can build up over time. Another common thing that we have to watch for when a patient's on amiodarone is prolonged QT intervals. Those can cause even more problems with dysrhythmias, so you should be checking a patient's QT interval at least every shift if a patient's on an amiodarone drip, and know if it's getting too long. So continue to follow the series. We'll talk about some more drips we commonly see in an ICU setting.